Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Dr. John H. Rex. He's a chief medical officer for a company called F2G Limited. It's an antifungal biotech company. And John studies antimicrobial resistance or antibacterial resistance, which is going to be the focus of the podcast. So welcome, John. Thanks for coming.
Oh, thanks for inviting me.
Yeah. So tell me, is there a difference, by the way, in antimicrobial versus antibacterial resistance? I use both terms, and I know one's probably a layman's term, but that's the first question.
Antimicrobial resistance, microbe broadly really refers to any living organism. So it could be a fungus, it could be a parasite, it could be a virus, it could be a bacterium. When you say antibacterial resistance, you're coning down to that segment of the tree of life, and you tend to have to do that. Solving one problem doesn't solve the other problems. The drivers are similar. The reasons for resistance are the same across all of the different varieties, but the solutions and also the relative impact's different. So I think it is it's helpful to be precise enough for a little bit of focus.
Okay, makes sense. So how long have you been working in the, I guess they call it the AMR field, or is it called something else?
AMR works, and there's that M word, antimicrobial resistance, which, but AMR generally, people in this space are generally talking about antibacterial resistance, as I've said. So I've been doing this my entire professional career. So I'm my deep background is that I'm a physician trained in internal medicine and infectious diseases, and I spent about the first 15 years of my career working as an academic medic. My focus at that time was on new drugs for fungal infections, and that's what I currently do as the Chief Medical Officer of F2G. And then about a little over 15 years ago, I moved into regulated industry and became the head of anti-infective development at a pharmaceutical company called AstraZeneca. And we ultimately brought several drugs to market, and I led that team during that time. We finally sold the business unit to some other companies, as sort of the typical rearranging pattern of pharma. And I went freelance at that point, and now consult and help with the development of antimicrobial agents broadly across the entire industry.
Yeah, I guess a hot part of this topic is, antibiotics and how it doesn't seem like barely any are coming out, or maybe are even in research. I don't know. Yet we're having certain microbes that are highly resistant to a lot of antibiotics. What are your thoughts there? What's the state of the industry? What's the state of care surrounding that area?
Well, you've said it well. It's sort of there's this curious paradox. It's, antibiotics seem like a great thing to have, and why is it that we're so fussed about antimicrobial resistance? And a shorthand version of it is to say that there are three challenges. They're hard to discover, they're hard to develop, and nobody pays for them. And each one of those lends the support to the thing that drives companies in this space out of business. But and one pretty topical way to see it is through this current lens of COVID-19. Think about, COVID-19, which is a coronavirus, and we've actually got some other coronaviruses around. How about, think about SARS, one that was a big news a few years ago. Remember that one? Well, SARS kind of came,
and MERS.
SARS and MERS, they kind of burned themselves out. But at the time, they threatened to do what COVID-19 has done. So let's just sort of rewind the clock to last summer. And if I'd said to you, Richard, I've invented a new drug for SARS, what would you have said? I said, well,
I would say, wasn't that like eradicated a while ago? Who cares?
Yeah, who cares? And I'd say, well, it could pop up again tomorrow as a pandemic. And you'd say, okay. And nothing really would happen. And so the challenge with an agent for SARS, and I could sort of invent the same story about COVID-19, last October. If somebody had discovered the virus in the lab and said, look, here's this virus, it could become a pandemic.
Well, this was a movie, I would say, my mortgage payment or my life support is going to kill me faster than a pandemic like that. It's a bad joke.
But that's kind of the essence of the problem. And another way to say it, and it's a bit of language that we tumbled into a few years ago when we were thinking about this whole problem of antimicrobials, is that antibiotics are the the fire extinguishers of medicine, and they really are like fire extinguishers in a lot of ways. I've got a fire extinguisher in my kitchen. You've probably got one in your house somewhere. And if I were to say to you, well, have you used your fire extinguisher today? Your temptation is probably to say, no, you haven't really used it. Well, let me try another analogy for you. We'll come back to the fire extinguisher. Do you have life insurance?
Yeah, that's something no one wants and no one thinks about, no one cares about.
Yeah, did you use it today?
No, otherwise I couldn't do the podcast.
Oh, well, are you sure you didn't use your life insurance today? Can I take it away from you?
Well, I'd rather not. My wife wouldn't like that.
That's right. And so it's one of those things where you've got life insurance, and it's the very existence of it is something you're willing to pay for. Fire extinguishers the same way. We as a community have agreed that it's a mistake to wait until the building's on fire to build the fire department and buy a truck and train some people to how to use it and put in a water supply. We do all that in advance. And every day when you go for a walk down the street and you walk past that fire hydrant, you are using the fire hydrant in a very real sense. It's not getting you wet, but everything else that it could do, you are relying on. It's what makes it safe to live, in a densely populated urban area. We know if house or building A catches on fire, we can do something about it before building B. And indeed, we could probably shut it down, but it's still just a grease fire in the kitchen. And so, that's the thing about antibiotics is that they're like that. One of their best and highest uses is I walk into the hospital, I look at the high-end antibiotic on the shelf, and I say, that's wonderful that that's there, and I intend not to put it into anybody today unless there's really a crisis. And that's the economic challenge of antibiotics. It's a space where if I invent a brand new high-end antibiotic, and we've had several companies do that recently, brought it to market. Everybody says, wow, that's a wonderful thing. I am so glad you did that. That's special. It's so special, we're not going to use it unless we really, really have to. And that, from a societal standpoint, that is absolutely the right thing to do. Every time you use an antibiotic, you run the risk of driving a little creation of some resistance. You don't want to use it unless you must, but when you want it now, not tomorrow, not next week. You want it now, and suddenly its value becomes nearly infinite. Well, the deal is you can't have it unless you're willing to have it always ready in the pharmacy. And and again, to come back to COVID-19, we're now seeing the cost of not having a fire extinguisher. The difference between not having anything at all is life and death for some folks. 6 months from now, when we better understand remdesivir and other things, it will become progressively safer to be exposed. But right now, not having a fire extinguisher do you in.
All right. So, question here: how about if you made a microbe-specific antimicrobial or antibiotic instead of broad spectrum? Would that change the picture?
I mean, not a lot. You still have to use it, and let's think about what it costs. What is the cost of creating an antibiotic? It's that's the generic cost of creating any drug. You're typically going to have spent between, the industry estimate is $1.5 billion just to get to registration. But I've got some specific numbers recently for antibacterials, which are in the range of $500 million to $1 billion. And the all-in cost, a good example is a company called Akin that brought a new mechanism and updated aminoglycoside to the market and then went out of business. And they had spent, by most estimates, somewhere around $600 million at the time they went out of business and sold basically for cash. And that was just the cost to get the thing to market. If you then want to have it available on the market, you just want to run the plant that makes the drug and have the supply chain, and so that it's possible for me in the hospital to say I'd like to use it, and I can go get some in a reasonable period of time from some depot, maybe somewhere else in town. But within 12 hours I can have it. You're going to need to spend another $25 million a year to run that plant, and there'll be other costs that you have to do in terms of maintaining the data package, and after the initial approval, there's other work to be done. The round figure estimate is that at the moment you are approved, I hand you the approval, I hand you the facility that makes the drug, I introduce you to the people who know how to make the drug. You need $400 million to break even 10 years from now. And unless
it sounds like a broken model. What's the solution?
Well, the solution is that we have to think about antibiotics like fire extinguishers, or like life insurance. And there was we put together a group, mostly in Europe, that ran like 2014 to 2017. This project that was designed to talk about the answer to your question. Well, what are the choices? What are the different ways that you could fix this problem? And the group spent a lot of time thinking about how to define the problem, and what the range of choices would be. And broadly, the group ended up dividing the kinds of things you could do into two categories. There's what they call push, and then there's pull. And push incentives are things like grants, making funding available to small companies or to academic investigators. And I noticed that you interviewed one of my colleagues, Kevin Otterson, recently, who is the executive director of CARB-X, which is a really just an outstanding concept. The U.S. government and Wellcome Trust and at this point several other governments have gotten together to put $500 million and a bit more than that into play to as early funding. So if you've got an idea and you want to get up into go from preclinical into phase 1, you can get money for an idea. That's called push funding. But that's only one part of it. You then have to pay for the existence of the drug once it's on the market, and that's where pull funding comes in place. And so here we talk about the idea of, if I bring an interesting molecule to market, we, the community, need to somehow pay for that drug like a fire extinguisher. You need to pay for it whether you put it into a human being or not. So it's so-called volume D-linked reimbursement. Somebody says, an example of it is something the UK government's doing right now. It's the first example we've ever seen of this in the world. The UK government announced, they've been working on the project for 4 or 5 years, but they finally got to the stage where they said, we are going to buy a couple of fire extinguishers, 2 antibiotics. We'd like to identify 2 antibiotics that we want to be sure we have available to us. And this is really the National Health Service of England that is doing this. And they are now in the process of defining the rules of the road for companies to apply. And what they're hoping to do, in round figures, is contract for 2 antibiotics, for each of which they pay 10 million pounds a year. And what the 10 million pounds a year would buy them is the antibiotic, whether or not it gets put into a patient or not, fire extinguishers.
I mean, we stockpile vaccines, we stockpile emergency gear, and why can't this be recast in that way? It doesn't make sense.
It could. It's a very similar concept. We are, as you say, we're quite willing to stockpile certain things, and there's a certain amount of that's already happened. BARDA, the U.S. Advanced R&D Agency, has some of that stockpiled. I guess I'd say BARDA has been focused on bioterrorism, biothreats, and also to some extent pandemic threats. And so its scope has been constrained within that space. But we are now seeing COVID-19 is really waking a lot of people up to the whole notion of preparedness, and there's fundamentally no reason why it couldn't be BARDA that chooses to, or there's the U.S. government's mechanism for having a certain number of fire extinguishers available. Entirely possible. There's also some legislation currently floating around, being developed. Floating around is too loose of a term. It's being developed right now that if it moves forward, would create for the U.S. a concept kind of like what the UK has done. It is to define the idea that there's some antibiotics that need to be bought on a we just want to have it available basis, and you've got to pay a reasonable amount for that. And that would actually, that's the big fix. That would be the pull incentive that would make it possible for a company to make money in the antibiotic space so that they can get return on what is hundreds of millions of dollars to bring the product to market.
Well, what's the preference here? Is the preference to make a microbe, bad guy specific antimicrobial, or is it to do more broad spectrum?
Broad versus narrow is an interesting puzzle. And I'd say that to answer your question at a high level, the general focus remains broad, but sort of within certain parameters, I should say. And so let me take that apart. Broad is a relative concept. You can put bacteria into certain buckets, and the most useful way in general to bucket antibiotics is, let's say, syndromically. If you develop pneumonia, not in the hospital, what's called community-acquired bacterial pneumonia, the list of typical causes of that is quite short, and so only a couple of things I need to cover if I think you've got community-acquired bacterial pneumonia. So an antibiotic that's broad enough to cover that is relatively easy to use without needing a whole lot of diagnostic machinery. And the diagnostic machinery is actually kind of tricky for some of these diseases. It can be hard to know precisely what's causing your community-acquired pneumonia because we all live in a sea of bacteria, and many of the bacteria that cause illness are also normally present on our bodies. I mean, that's one of the big challenges in this space. And so you typically want your antibiotic to be broad enough. Very, very narrow spectrum drugs are they're harder to develop and they're harder to use than the agents that have at least some breadth of coverage. And so for that reason, most drugs end up doing more than one bacteria.
So is it helping or hurting that we're able to get, sequencing and genomic data much more quickly to identify if there's an overabundance of one pathogen, let's say?
It's one of those things where you'd think it would help a lot. It has turned out to be harder than you might have guessed intuitively to take advantage of the advanced molecular technologies that we have these days. The sense of how you make a diagnosis really is so much tied up with, tied into the fact that we are covered at all times with bacteria that could be pathogenic. You take, so if I were to do a PCR test on any of us right now, who was looking for E. coli, you'd be positive. We'd all be positive. We got in our gut. There's no way to not have the signal of E. coli if I take a reasonable sample from you. And most of the time it's not a problem. But do you currently have if you develop pneumonia in the hospital and I detect E. coli in your sputum, does that mean anything? Well, it may or may not, because I would detect E. coli in your sputum whether or not you had pneumonia, and that's the challenge. And it's important to differentiate that from some other things, like tuberculosis is an easy one to talk about. With TB, it is never, ever, 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 ever normal to have the DNA signature of TB in your sputum. It's just not, it's not a normal commensal. So if I detect anything, I can say, well, that's TB. So I can set my sensitivity way up high.
Okay.
Whereas I can't do that for ordinary bacteria and the far more common typical bacterial infections.
Yeah, that's interesting, all these trade-offs. Okay. So what hopefully the worst bacteria that are killing the most people, for instance, right now, and let's say, hospital settings or acute illness settings, are they ones that are normally there at all in people, or unfortunately, do they tend to be available in people as well, and therefore hard to discern if they're the real problem?
It is frustratingly more the latter than the former. So the pathogens that are never, ever normal are TB would be an example, gonorrhea would be another, probably name a few more. So, the viruses, mumps, measles, those are never normal. But the far more common scenario, like if somebody winds up in the hospital after a car wreck, and they've got a broken leg and maybe they have a problem with breathing because they've cracked some ribs or something. When they develop pneumonia, they're going to develop pneumonia with the bacteria of their gut. It's going to be, E. coli or Klebsiella. And those things, they brought it in with them, and there was nothing you could do to, take it away from them. As a matter of fact, killing all their E. coli would be a bad idea because the E. coli in their gut is part of your microbiome. You actually you live in symbiosis with your bacteria. It's only when they get out of their usual spot that you're unhappy. All the rest of the time, you want them because they're doing some very interesting things down in your gut that are part of your vitamin production and stimulating your immune system and all kinds of really helpful, healthy person stuff.
Well, I mean, even an adjunct to giving antibiotics doesn't seem to be there. Take these probiotics, take these prebiotics. On day 3 of an antibiotic course or day 7, to get you back to a more normal microbiome. I mean, I don't even see that as part of the standard of care.
Well, you can, and I think some people do, take advantage of taking some yogurt or other sorts of things. That sort of stuff will help. Anecdotally, I think it does. But the broader sense, your question was narrow versus broad, and why don't we, have antibiotics that have some sort of surgical precision for the bug you want? And I think it's a very profound question. Why can't we be that precise? And in Star Trek tricorder land, in theory, I could be that precise. At least in some imaginary sense, because at the end of the day, when I have pneumonia, it is usually due to one thing, and in that circumstance, I could, in theory, reduce it to one therapy and try to leave everything else in my microbiome alone. In principle.
Well, why not? How about this? Why not get your microbiome shotgun sequenced every 6 months? Then if something happens to you and you're hospitalized and you have a terrible infection, they do the same thing and they compare the two and they at least have a sense of what normal was, and then perhaps using a cocktail of very specific antibiotics get you back to the way you were by targeting the overgrowth of the bad ones to bring you back to a regime that looked like before.
Interesting. Well, there are parts of that I think are this idea of knowing what your normal looks like and how to get you back to normal. I like that idea. The thing that I think might still be the hitch and the get along would be that just putting your microbiome back to some we'll call it normal state might not be a swift enough therapeutic intervention to reverse the infection in your lung. I mean, I think that's an idea that when people talk about non-traditional therapeutics, non-traditional interventions, you can interfere with bacterial activities. For example, virulence inhibitors, this concept of rather than kill the bacteria, let's just get in its way. And one that gets talked about a lot is things that cause the bacteria to no longer stick to you. That's a common theme. In order for a bacterium to infect you, it has to adhere to you somehow. It has to not get washed away by your normal processes. So what if instead of killing the bacteria, all I did was make it so that it couldn't stick? Well, that's nice, but if I've got an active infection and the bacteria is chewing its way through my lung tissue, is that fast enough to give me relief before the bacterium kills me? And the limitation of most virulence inhibitors has been that it has been really the speed and the potency of the response. A true small molecule antimicrobial has an effect that is, within hours, dramatic, stunning. The virulence inhibitors, you can see the effect, but they're just not as potent. It's not as fast.
Well, I mean, if you want to get even more complicated, how about again, looking at before and after microbiome, and then doing a combination of some phage therapy, a little bit of phage therapy, a little bit of, bacteria-specific antibiotics, a little bit of bolstering of the quote-unquote good stuff, and perhaps a therapy like that, it would be very complicated, and sadly, it will probably never be approved. But that may be the best way to nudge things in 5 different ways back to the previous.
Well, yeah, I think that it's at sort of a very high level, at which point that makes good sense. And it's effectively what we hope happens when we give you, a few days of an antibiotic and you start to feel better, and and your microbiome rebuilds itself, and you're hoping that you will sort of automatically, you will, by whatever magical process you got your normal microbiome to begin with, you will restore it to something that resembles normality for an adult. And it is, the microbiome stuff has intrigued us just in the whole area. The whole field's been just fascinated by microbiome. It's just wildly complex. And you talked earlier about how do I characterize my microbiome? The complexity of sequencing and which parts of the sequence do I pay attention to, and then how do I put it back? And because we don't grow a lot of these organisms, we know what's the proportion of this, that, and the other that you need. Someday I'm hopeful that we will better understand what normal means and how to get back to it. Right now, to my read of the area, it remains a big guessing game. A lot of energy going into it, and I would love to see somebody solve the puzzle. Right now, it feels like it is such a complex problem that we're still sort of feeling our way into it.
You mentioned that you do some antifungal work. Is it any more difficult, or do you need a different set of tools to look at antifungal or antiparasitic or antibacteria or antiviral?
Viral, right.
Yeah. I mean, how different are all these creatures, and can you apply a lot of the toolbox, or is it a whole new set of problems?
It tends to be largely new sets of problems as you go from one space to the other. So let's just for a moment compare bacteria and fungi. Fungi belong to a higher class of life called the eukaryotes, as opposed to bacteria that belong to a class called the prokaryotes, and it has to do with the level of intracellular organization. For example, the eukaryotes all have a cell nucleus. They have a higher level of organization, and you and I are eukaryotes, just as fungi are. And so we share a lot of similarities with fungi. And so it has historically been easier to find antibacterial agents than antifungal agents. Right now on the market for bacteria, there are probably at least 15 or 20 discrete classes of effective antibacterials. You'll know some of them. Penicillins, sulfas, tetracyclines, erythromycin, all those sorts of things. You go into the fungi, where despite people looking over time, it really reduces to 3 major classes and 2 minor classes, and that's it. And in the 2 minor classes, there's only one of each one of them. There's no variation there at all. And in the other 3 classes, effectively, if you're resistant to any compound in class A, you're resistant to all the compounds in class A. So we've really only got a handful of antifungals, and part of the reason for that is that it's harder to find something that kills the bug that kills the fungus without killing us. So we sometimes joke it's really, really easy to kill bacteria and fungi. It's easy. Steam, fire, bleach, they work great. The trick is to do so without harming you. And this replays all the way back to the very, very, very first antimicrobial, salvarsan, when Ehrlich discovered the arsenicals for syphilis. He was actually startled to find this compound that actively reduced killed off the treponines, and began to develop in human beings. And it certainly does work if it didn't kill you. And there was up until fairly recently there was a parasite And parasites are all, share some of the same problems as fungi. We actually have a lot of affinities with them. The leading therapy for the parasite called sleeping that causes sleeping sickness was an arsenical that had been developed in the 1940s that if it could cure you, but one time in 20 it would kill you. That was it was tough drug. You shouldn't spill it on your skin because it would burn your skin. It's just horrible stuff. Imagine injecting that into your veins. What a deal. So, but now, after many years of effort, there actually is a pill that treats that parasite. So, there just aren't. You tend to have to solve the fungi, the parasites, and the viruses are another example. It's almost a one-by-one phenomenon. The viruses are a particularly good example of that. The drugs that work for HIV work for HIV. They don't work for other viruses, and it's just it's the exquisite specificity of the antiviral life cycle enzymes that cause that to be true. There are a few cases where you got some generalizability of the antiviral across a few viruses, but it tends to be really quite narrow. And so every one of those costs hundreds of millions of dollars to discover.
But do you get the sense that there are broad-spectrum antivirals, broad-spectrum antifungals, or because of the biology of those creatures, it's unlikely that they exist?
For antifungals, you can get breadth within certain limitations. The company I'm working with has a compound that's pretty broad within a collection of fungi called the mold fungi, the ones that are kind of filamentous, the fuzzy ones. And if you look at the other antivirals, sometimes they cover. The other antifungals, sometimes they cover broadly. Sometimes they're a little bit more narrow. But you look at the viruses. The history with the viruses tends to be that they're very one at a time. The closest, there are families within the viruses. There are the DNA and the RNA viruses, and some of the DNA viruses lump together in a group that. So the pox viruses are closely enough related that sometimes drugs work over 2 or 3 viruses, but they tend to be very, very fussy about what drug they'll respond to. And the viruses are also tricky to develop for because they tend to be very host specific. So the virus that causes there are pox viruses that cause smallpox causes disease in human beings, but doesn't cause disease in animals. And there are versions of those viruses that cause disease in animals but don't cause disease in man. So you end up struggling with even your fundamental models. So you take even just influenza. That virus. You're really the only living system in which you can really get a model of influenza that resembles the human version of influenza is human beings. The virus just doesn't replicate in other species. It is finely adapted to us, and that's the only place where you can work. So it actually even makes discovery harder because with the bacteria, I can make a pneumonia model with the pneumococcus in a mouse without, and it's not exactly like the human disease, but it's a lot like the human disease. I can do that with pretty much any bacteria. I can create a disease in an animal that is close enough to the human disease to be a helpful and instructive mimic. I can also do that with the fungi. In general, I can create a model of fungal infections. Viruses, they're completely different beasts.
I wonder if there's, I've learned recently that for a given bacteria, there's not just one phage, but there can be hundreds of different kinds and thousands. I wonder if, if we're infected by a virus beyond our cells, there could be bacteria that could be introduced to gobble up the energy and the infectivity of a given phage, or a molecule that can be created to do that. To keep it busy, so it leaves us alone.
Interesting theme. Phage are interesting critters, and clearly they are well described as the viruses of bacteria, and they often kill. Actually, you can clearly demonstrate that you can kill bacteria with phage. But phage are also an example of a very good parasitic adaptation, because how do phage sustain themselves? By living on bacteria. What would be an example of a really stupid phage? A phage that killed all the bacteria. You'd be done and dusted. And that's actually an interesting thing about living in balance with things. So, think about the E. coli in your gut. Your fecal flora is full of a variety of bacteria, E. coli, some a whole bunch of stuff. Would you describe those as parasitic? Well, no. You'd say, actually, I live in symbiosis with those things. As long as I stay in their spot and I stay in my spot, we actually like each other. And so.
Well, then if they make you vitamins and you feed them, then they're your pet.
That's right. That's right. And so that's a very useful relationship between the organisms. And so this notion of what does it mean to be a phage who's going to kill bacteria? Well, if there was an uber phage that could kill all of its host, that uber phage long since went away. And the inverse is that the phage that are currently existing have self-selected to not be the uber killer phage. Otherwise, they would burn out. And that, in a way, that's actually part of the reason why phage therapies for bacterial infections run up against, at least this is my personal, teleological analysis. Why is it that phage therapy does not, you even put together cocktails of phage for a given bacteria. Why is it that it's hard to get above 90 to 95% coverage of the bacterial strains that are out there? You say, I'm going to collect a bunch of phage that kill off, bacterium X, and I'd like to develop enough of them to actually use it as a reliable therapeutic. People have done that. And they say, well, one phage will only get 60%. Let me find another one that gets 60%. Let me find another one. Let's put together 5 or 6 or 7 of them. The data, I'm not a phage developer, but what I've seen in the companies that have done this is they struggle to get north of 95% coverage, even though they're picking a whole bunch of different phage. They're looking for them. They're struggling to get above 95%, and I think that reflects the fact that. You're a bad phage if you kill everybody. And there's a fundamental biologic selection mechanism going on with phage so that they stay just friendly enough with at least a subset of their target bacteria that they never run out of places to go.
Well, maybe there's some cooperation amongst the phages when they're maybe there's quorum sensing. Maybe there's a lot of stuff going on where there's coordination. They say, "Hey, don't kill everything."
Yeah, don't kill everything. And I'm not a phage biologist, so I can't speak to whether there's even a plausible biology for quorum sensing in phage. But this notion that phage, they are a classic parasite, and their goal is to live. Their goal is to live. And you're a bad parasite if you kill all of the exemplars of your host. You just don't want to do that.
So what's the I don't know. Is it just going to be a forever inching along? Fungus by fungus, so. Bacteria. What's the future?
Yeah, you got to think so. And if you will, if I could sound like a terrible downer here, saying all this resistance and all this difficulty, and there's all these newspaper articles about how hard it is. But in general, we have been able to invent the antimicrobials that we needed. It can require a lot of effort. And again, COVID-19 has given the entire world a visible lesson in what it takes to get there. But do I think we'll have a therapeutic for COVID-19? I guess I do. We've already seen that it's at least possible to show that one antiviral has activity, remdesivir. We don't know a lot about it yet, but it certainly did, at least in the early data, suggest that it was blunting the course of really severe disease, and that's kind of what you'd expect to see. And fingers crossed, we'll also come up with a vaccine. But once again, it's going to be with a lot of effort to get there. And I think that is, that's the lesson. But are we done after we've done COVID-19? No, we're not. Think about SARS, think about MERS, think about Zika, think about Ebola. Right now, how much energy is going into developing something for Zika. I don't think there's a ton. I don't know for sure the total amounts, but it's certainly not something that seems to be getting lots and lots of energy. And until we sort of think about the whole antimicrobial preparedness problem and are willing to support the industry even on days when it doesn't look like we need it, did I need a drug for COVID-19 a year ago? No. Would I've yet today I'd pay $1 trillion for it. You wish we had the ability to maintain a reasonable level of preparedness for these sorts of things, so that when we need to have a tool to at least get us started, we've got it. And I think we will. I think we're going to invent new antibacterials. There are, Carbex has some very interesting stuff in its portfolio. Cross my fingers, we'll get at least one or two really new antibacterials over the next 5 years, and crush fingers. I think the path forward is not bleak. It's just tough.
Well, very good. Well, John, what's the best way for people to find out more about your work in general?
So, one of the things I do in the industry is I maintain a website and I have a newsletter and a blog. And the newsletter is called AMR.solutions. So if you just go to AMR.solutions, you can sign up. It's free. And I send out a newsletter. There's no schedule. It's when I have something interesting to say. So when I see something that, if you're a developer, you're interested in the space that you ought to know, that's when I send out a newsletter. And all the old newsletters are posted on the website. And and that's a pretty good place for somebody to get started with thinking about this area. Just look at some of the recent newsletters, and you begin to find links that take you deeply back into the background material in space. I've been connected to all the big initiatives over about the past 10, 15 years, and so I try really hard to take the knowledge I've got, and when I write a newsletter, it'll tell you not just what you need to know, but why you need to know it and how to read more about it. So I make a real effort to communicate the background material.
Well, very good. Well, John, it's been a good call. I appreciate it. Thanks for coming on the podcast.
Well, likewise. Thanks for making time. Appreciate your interest in AMR, and stay safe, man.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.